Hello and welcome to the Project iCare podcast. This is a recording for healthcare providers who want to learn more about improving care for patients who might be at risk for HIV. I'm your host, Dr. Casey Claiborne, a clinical psychologist and research scientist at the University of Texas Dell Medical School.
And my name is Sydney. I will help narrate this podcast by defining terms, explaining concepts, and citing statistics that are relevant to the topic.
Have you ever wondered if any of your patients might be at risk for HIV infection? Or how to talk to your patients about their sexual health and HIV prevention methods? What is PrEP? And will there ever be a vaccine for HIV? Well, that is exactly what we're going to be talking about on this week's podcast. Today, we are podcasting from Austin, Texas with Dr. Aliza Norwood. Dr. Norwood is an assistant professor in the departments of population health and internal medicine at the University of Texas Dell Medical School. She is also a practicing physician at CommUnityCare who specializes in HIV primary care, PrEP, and transgender care. Welcome, Dr. Norwood.
Thanks for having me.
So, Dr. Norwood, we've seen lots of advances in the field of HIV over the last 20 years from a scientific perspective. Talk to me about how important it is for focusing on HIV prevention at this time.
Great. So we've had a lot of advances in HIV care overall in the last few decades. So it's a really exciting field to work in because something that used to be really a death sentence for patients is now a fully treatable disease where patients can live just as long as anybody else and have a great quality of life. Even though we've made all these advances, it's still really important to focus on HIV prevention because there are still many new cases of HIV every year. So even though we've made progress in terms of treatment and prevention, it's still a reality that not all of these methods that we have work for every patient. And so we want to make sure that we offer more options, more ways that patients can protect themselves that fit with their life. In 2017, there were over 38,000 new HIV diagnoses in the US. In Austin alone, there were 328 new HIV diagnoses and over 5,000 people living with diagnosed HIV in Austin.
Wow.
So we are trying to help people protect themselves. The other thing that we try to focus on in the field of HIV prevention is really recognizing who gets HIV and whether there are health disparities in terms of HIV incidence. When we look at the numbers, there really are. So HIV incidence in certain demographic groups really reflects ingrained health disparities, both in Austin and in the United States. For example, over the last few years, HIV incidence has fallen about 14% among white men who have sex with men who may identify as gay or bisexual men, but remain the same among gay and bisexual African American men, and actually increased by 12% among Hispanics and Latinos. An interesting study by Crosby et al. In 2007 looked at differences in sexual practices to explain this disparity, and they found actually that fewer Black MSM, or men who have sex with men, compared with white MSM, engage in high-risk sexual risk behaviors, and they were looking at HIV-negative men. So this showed that individual sexual practices don't seem to prove to be contributing to the racial disparities in HIV incidence that we see. This study shows that there are risk factors that go beyond individual-level behaviors. Those may include system-wide problems such as access to care, education, and stigma. So what we're seeing is that there are racial disparities in terms of who is getting access to some of the newer prevention methods, who is getting access to education, and those disparities are reflected in new HIV incidences. So again, just like we have birth control, many different options for birth control, we want to have a whole toolbox of options for people so that they can choose what works for them. We know that from the Centers for Disease Control also tell us that actually less than 10% of people who are at risk of HIV are using some of these newer options that are available, like PrEP, which we'll talk about. There are a lot of people who could benefit from prevention tools and who either are not aware of it or are not getting it.
PrEP, or pre-exposure prophylaxis, is a daily medication that reduces the risk of contracting HIV infection from sex and injection drug use by more than 90% and 70% respectively.
So tell me more about who's at risk for HIV.
So the key thing to remember is that HIV can affect anyone. So the CDC actually recommends that everyone between the ages of 13 and 64 be tested at least once in their life, regardless of risk factors. There are certain practices that I'll go over that can increase a person's risk for contracting HIV. So HIV is transmitted through blood, semen, or preseminal fluid, rectal fluids, vaginal fluids, and breast milk. So we have to remember that fluids from an HIV-infected person have to make contact with a mucous membrane or damaged tissue or bloodstream of a non-infected person in order for that infection to take place. So this is just getting back to the fact that we know that it cannot be transmitted through air or water or hugging or closed-mouth kissing, any of those things. In terms of relative risks for different practices, we know that anal intercourse has a higher risk of transmission of HIV than vaginal penile intercourse. So specifically, receptive anal intercourse, which is also known as bottoming, has the highest risk in terms of sexual practices. So about 140 out of 10,000 people. That's the general risk.
Now, is that risk the same for men and women?
So for receptive anal intercourse, the risk appears to be the same for men and women, but most of the data that we have is in men who have sex with men. In terms of insertive anal sex or topping, there's a little bit lower risk, so about 11 in 10,000. And then it's a bit lower for receptive vaginal sex, about 8 in 10,000, lower for insertive vaginal sex, so it's a heterosexual couple, and the risk for the man would be 4 in 10,000.
Okay.
And then extremely low risk for oral sex. In terms of non-sexual risks, injection drug use does pose a risk of about 63 in 10,000.
So do you think we've had a change in that since the opioid epidemic has kind of become more pervasive in the United States?
Absolutely. So we know that with the opioid epidemic, more people are turning to heroin or opiate substitutes, opiate drugs, which are cheaper and more available in many places. It's especially hit rural communities very hard. And so people who may have a prescription opiate medication as a gateway to then injecting cheaper and more available drugs, we have seen incidences of HIV and breakouts of HIV in smaller communities.
In 2015, Indiana's State Department of Health began an investigation due to an increase in HIV incidence that was traced back to the sharing of needles while injecting the drug oxymorphone, a powerful semi-synthetic opioid analgesic or painkiller. In a community of 4,200 people, 135 were diagnosed with HIV, and of these, 80% reported injection drug use. This example demonstrates the vulnerability of small communities to outbreaks of HIV due to the prevalence of unaddressed comorbidities, such as substance use disorders.
Just as another aside, things like spitting, biting, sharing of sex toys, those are all really theoretical risks and negligible, so things we don't really worry about.
That's really helpful.
In terms of the risk for healthcare providers, percutaneous needle stick carries about a 23 in 10,000 risk. And we always recommend that, if healthcare personnel receive a percutaneous needle stick accidentally, that the blood from that needle, if there was contamination, they track back to the patient and test that patient for HIV and give post-exposure prophylaxis until it is determined that the patient does not have HIV. Or if they do, then post-exposure prophylaxis would be given.
Okay, that's really helpful. So you just talked about PrEP, so post-exposure prophylaxis. Tell me more about some other HIV prevention strategies.
Yeah, so in terms of sex specifically, if we look at different types of practices that can lead to HIV contraction, you can talk about sex. The only 100% foolproof prevention is abstinence for sexual transmission, obviously.
Which is probably unrealistic for most people.
For the vast majority of people, it's very unrealistic. I usually make a birth control analogy, so we're trying to talk about as many options as possible for people to protect themselves. So other options include condoms. We advise using condoms with lubrication because that decreases the incidence of breakage of condoms. And then the only currently FDA-approved pill for HIV prevention is PrEP, which stands for pre-exposure prophylaxis. In terms of people who use IV drugs, obviously abstinence also, or referring patients to counseling and rehabilitation services or to an addiction medicine specialist. For people who have ongoing use, needle exchange has been proven to be very effective in reducing the incidence of HIV. So that means using sterile needles and works, not sharing needles. If the patient absolutely cannot get access to clean needles, then they should at the very minimum be cleaning with bleach. That has been shown to reduce the risk of transmitting HIV, but does not get rid of that risk completely. So needle exchange really is the preferred option for patients who are using. In terms of maternal to child transmission, we know that treatment of the mother during pregnancy can drastically reduce the risk of transmitting to her child. And then for people who are living with HIV, we know that something we term treatment as prevention is very, very effective as well. So that means making sure that everybody who we've diagnosed as having HIV gets the appropriate treatment and becomes virally suppressed.
Okay.
So viral suppression means that their HIV viral load is undetectable. And we know from newer studies now that patients who have an undetectable viral load living with HIV basically have effectively no risk of transmitting. So it's a great HIV prevention strategy overall because one, we're increasing the quality of life and lifespan for people living with HIV, but we're also reducing the risk of them transmitting HIV to others.
That's awesome. So I'm thinking what you're talking about is the U equal U. I keep hearing that statement all the time.
Yeah.
So tell me more, what exactly does U equal U mean?
U equal U is kind of a catchy phrase that refers to this idea that if you have an undetectable viral load, then you're unable to transmit the infection to others.
So undetectable equals untransmittable.
Yes.
Okay.
It's a really important concept for us as providers to understand. Obviously, we want to treat every patient for their own health, but it's also really a public health mandate that we make sure that patients living with HIV are retained in care, that they have access to the correct medicines, and that they're virally suppressed.
Okay. So if I have HIV and my viral load is undetectable, and U equals U, so undetectable equals untransmittable, does that mean that I can have unprotected sex and not transmit HIV?
Great question. When we look at the data, people with HIV who take antiretroviral therapy as prescribed and maintain an undetectable viral load have effectively no risk of transmitting HIV through sex. So there were 3 recent, really landmark studies. They were called HPTN 052, Partners, and Opposites Attract. And these 3 studies showed the strongest evidence to date that treatment prevents sexual transmission of HIV, or what we call treatment as prevention. So in all 3 studies, there were no linked HIV transmissions when the HIV-positive partner was virally suppressed. And these studies represented over 74,000 unprotected vaginal or anal sex acts over 1,500 couple years. So there was a lot of unprotected sex and no HIV transmissions when the HIV-positive partner had viral suppression of their HIV. So the caveat is that these patients who were definitely virally suppressed were in this research study and in care. Your patient has to know that they need to continually follow up with their doctor and have their viral load tested consistently and, be retained in care and be tested appropriately so that they know that they're really virally suppressed. But the great thing about U equals U is that it does undo some of the stigma that people living with HIV have, and it reinforces that they can have healthy lives and they won't infect others if they stay in treatment and remain virally suppressed. So I think as providers, it's really our role to make sure that they have all the information that we have for them to make the most informed decision about what makes sense for their lives.
Absolutely. That's great. This has been a Project iCare podcast with special guest Dr. Aliza Norwood. To learn more about Dr. Norwood and her work, check out our website where this information will be linked under today's podcast description. If you like this podcast and would like to learn more, check out our website, linked in the description below, or find us on Facebook at UT Health Innovation Lab. Thanks for listening.